Varun, hi Varun, you are ready?
Good morning, ma'am. Yes, I'm ready.
Okay, good. So, Dr. Ravi, you are ready?
Yes, ma'am. Yeah,
So, Dr. Ravi, please introduce Varun and then you can start. Okay.
okay.
Thank you very much.
Good morning,
Dr.
everyone.
Preeti, yeah, please go ahead.
Dr. Varun is a third-year resident in Department of Palliative Medicine at the GCRI Ahmedabad, and he will presenting today common metabolic disorders seen in the palliative medicine. Okay, Varun, you can start.
Good morning, everyone. Today, my topic of discussion is common metabolic disorder in the palliative care and their management. Common metabolic disorders in palliative care we can found in our daily practice are hypercalcemia, hyperkalemia, hypokalemia, hyponatremia, hypernatremia, metabolic acidosis, alkalosis, hypomagnesemia and hypermagnesemia, pyrexia, metabolic bone disease, and the hyperglycemia. First, we start with the hypercalcemia. Hypercalcemia is the most common life-threatening metabolic disorders associated with cancer. It is a metabolic emergency and most common paraneoplastic syndrome. 30% of the cancer patients develop the hypercalcemia, more commonly in the advanced malignancy. And more common, it is seen in the lung, breast, head and neck cancer, or kidney, ovarian, multiple myeloma. Preferentially in certain histologies such as squamous cell carcinoma of lung compared to the adenocarcinoma or small cell lung cancer, squamous cell cancer have the more prevalence of hypercalcemia. Mechanism of hypercalcemia, there are three mechanisms. One is bone resorption, ectopic production of the parathyroid hormone related peptide, and excessive production of the 125 dihydroxy vitamin D3. First one is bone resorption. Bone resorption is stimulated by the local and humoral factor. Local factor are produced by or in response to the bone metastasis, while humoral factors are released into the bloodstream by the distant tumor. And by secretion of this local and humoral factor, it causes the increased activation of the osteoclast. This osteoclast produce the lytic proteases, including the lysosomal protease, metanoproteinases, and cysteine proteases, which dissolve the organic bone mass. And this osteoclast also contains the proton pump and their ruffled water, which secretes the hydrogen ions, resulting in the dissolution of the hydroxyapatite and the mineral component of the bone. At the molecular level, this osteoclast activation is regulated by the interaction between the three molecules. One is the osteopretigerin, second one is receptor activator of the nuclear factor kappa, and receptor activator of the nuclear factor kappa B ligand. So the mesenchymal stem cell produce the pre-osteoblast, and through this pre-osteoblast, the rank ligand is secreted, which causes the main mechanism in the synthesis of the osteoclast. This rank ligand and osteoprotegerin equilibrium may become the disrupted in context of the malignancy, so resulting in the uncoupling of the usual homeostatic balance between osteoclastic bone resorption and osteoclastic bone formation. Also, tumor cell either directly produce this rank ligand or stimulate the bone stromal to produce the rank ligand. And in addition, osteotrophic factors such as 125 dihydroxy vitamin D3, parathyroid hormone related peptide, and interleukin 1 and 6 enhance the rank ligand expression and diminish the osteoprotegerin expression. Local factors produced in response to a tumors like cytokine, chemokine, and prostaglandins also disrupt this equilibrium. Second mechanism of hypercalcemia is due to ectopic production of the parathyroid hormone related peptide. Hypercalcemia due to parathyroid hormone-related peptide production is also called as the humoral hypercalcemia, and it resembles the primary hyperparathyroidism biochemically with hypercalcemia. Hypophosphatemia, renal phosphate wasting, increase the tubular resorption of calcium, and enhance the osteoclastic bone resorption also cause this. The mechanism in this is bone resorption, which is primarily due to parathyroid hormone related peptide mediated, increase the activation of osteoclast to increase the expression of the rank ligand in the osteoblast. And other factors are also thought to contribute like cytokines and decrease the renal clearance of the calcium due to the PTHRP. Third mechanism is extrarenal production of the vitamin D. Metabolic activation of vitamin D to calcitriol and its effect on the calcium and phosphate homeostasis. And the result is an increase in the serum calcium and phosphate concentration. Like this chart showing ectopic production of 125 dihydroxy D3, which is resulting in hypercalcemia due to extrarenal hydroxylation of 25 dihydroxy D3 by 1 alpha hydroxylase to 125 dihydroxy D3, which is resulting in the increased gut absorption of the calcium, and it causes the hypercalcemia. Clinical features of the hypercalcemia are in general dehydration, polydipsia, polyuria, pruritus, in GIT related anorexia, weight loss, nausea, vomiting, constipation, neurologically fatigue, lethargy, confusion, myopathy, hyporeflexia, seizures, coma, in cardiology, bradycardia, atrial arrhythmia, ventricular arrhythmia, prolonged PR interval, and wide T waves. Grading of the hypercalcemia, it is categorized into the mild, moderate, and severe based on the level of the calcium in serum. Like 10.5 to 11.9 is mild, 12 to 13.9 moderate, and greater than 14 or equal to 14 is severe hypercalcemia. And if hypercalcemia found, then we have to calculate the corrected calcium. So the formula for corrected calcium is serum calcium plus 0.8 into 4 minus serum albumin. Management of the hypercalcemia in the patient with life expectancy of the years to months. Mild hypercalcemia, patient with asymptomatic or the mildly symptomatic hypercalcemia do not require the immediate treatment. However, they should be advised to avoid the factors which can aggravate the hypercalcemia like thiazide diabetic or the lithium carbonate, volume depletion, prolonged bed rest or inactivity, high calcium diet greater than 1000 milligram per day, calcium supplements, vitamin D supplement in excess of 800 international units per day, multivitamins which contain the calcium, and adequate hydration is recommended to minimize the risk of the nephrolithiasis. In moderate hypercalcemia, asymptomatic or the mildly symptomatic individual with chronic moderate hypercalcemia may not require the immediate therapy. They should follow the same precaution which is described above for the mild hypercalcemia. Acute rise to this concentration may cause the marked changes in the sensorium which require the more aggressive therapy. In these patients, we typically treat the saline hydration bisphosphonate as described for severe hypercalcemia. Severe hypercalcemia require the more aggressive therapy, which includes the volume expansion with isotonic saline, calcitonin, and bisphosphonates. So first we start with volume expansion with isotonic saline. Most patients presenting with the severe hypercalcemia have marked intravascular volume depletion. So hypovolemia exacerbate the hypercalcemia by impairing the renal clearance of the calcium. Isotonic saline for the 24 to 48 hour correct the possible volume depletion due to hypercalcemia induced urinary salt wasting. Administration of the isotonic saline at the initial rate of 200 to 300 ml per hour, then adjusted to maintain urine output of 100 to 150 ml per hour. In individuals with renal insufficiency or the heart failure, careful monitoring and use of the loop diuretics may be required to prevent the fluid overload. But in absence of the renal failure or the heart failure, loop diuretic therapy to directly increase the calcium excretion is not recommended because of the fluid and electrolyte complication and volume depletion resulting from a massive saline infusion and furosemide-induced diuresis. Second one is calcitonin, which is produced in the human primarily by the parafollicular cells, also known as C cell of the thyroid gland. And this calcitonin counter the parathyroid hormone activity and lower the calcium by inhibiting the intestinal calcium absorption and inhibit the osteoclast activity. Dosage of the calcitonin 4 units per kg sub-Q or IM 12 hourly, and if response is unsatisfactory, increase the dose to the 8 units per kg 12 hourly, and then if no response is there, we can increase the dose to the 8 units per kg 6 hourly. Subcutaneous injection have a rapid onset of action and usually in 2 to 4 hours, and maximum reduction in serum calcium of approximately 1 to 2 milligram per day. It is useful when combined with bisphosphonate, more so in urgent, life-threatening situation because of its rapid effect, while the bisphosphonate have a slower onset of the action. And adverse effects include the nausea, flushing, abdominal pain, local irritation at the injection site. Third one is bisphosphonate. They are the stable analog of the pyrophosphate, which is a naturally occurring regulator of the bone metabolism and cause a gradual fall in the serum calcium over a few days. But it not alter the PTHRP level or renal calcium reabsorption, rank ligand, or the osteoprotegerin level. So they may fail to control the humoral hypercalcemia of malignancy without the bone metastasis. The figure showing the mechanism of the bisphosphonate, which causes the compete with ATP and poisonous the HMG coenzyme pathway and causes the apoptosis of the osteoclast. Dosage of the bisphosphonate commonly zoledronic acid 4 milligram IV and wait at least 7 days before the reconsidering that. Pamidronate 60 to 90 milligram IV over 2 to 24 hours, abandonate 2 to 6 milligram IV over 1 to 2 hours. And non-nitrogen containing is flotonate, which is 1500 milligram IV or sub. Adverse effects are include hypocalcemia, transient renal insufficiency, and rare side effects include the renal failure, jaw osteonecrosis, ocular reaction like iritis, episcleritis, scleritis, or conjunctivitis. Acute phase reactions include the transient fever, malaise, myalgia, bone pain, and lymphocytopenia. Gallium nitrate, accumulates in the metabolically active region of the bone where it inhibits the osteoclast-mediated bone disruption and prevent the acidification and cell-mediated dissolution of the bone material by inhibiting an adenosine triphosphate-dependent proton pump in ruffled membrane of the osteoclast. It also inhibits the PTH secretion from the parathyroid in vitro, and it has been found to effective in both the PTHRP-mediated or non-mediated hypercalcemia. Dose of the gallium nitrate 100 to 200 milligram per meter square per day IV over the 24 hours for the 5 days. The main concern with the use of the gallium has been nephrotoxicity, hypophosphatemia, nausea, and administration time of 5 days. This is the study showing the effect of the gallium nitrate, which conclude that gallium nitrate is highly effective and superior to the etidronate for hypercalcemia. Corticosteroids. It has been widely used in the cancer-related hypercalcemia and rapidly inhibit the osteoclastic bone resorption in vitro, as well as reducing the calcium absorption from the gut. And their limited clinical benefit is chiefly confined to tumors that respond to the cytostatic effect of the steroid, like myeloma, lymphoma, leukemia, and occasionally breast cancer. When hypercalcemia occurs as a flare effect, which is caused by the endocrine therapy. Thus, their role in severe hypercalcemia is limited to the hematological malignancy, and oral prednisolone of 40 to 100 milligram per day is usually effective in these circumstances. Rank ligand inhibitor, which is denosumab, monoclonal antibody with affinity for the nuclear factor ligand, and it binds to the rank ligand and block the interaction between the rank to rank ligand and prevent the osteoclast formation, leading to the decreased bone resorption and increased bone mass in the osteoporosis. This demonstrated efficacy in patients with resistant hypercalcemia of malignancy despite the bisphosphonate therapy is now approved as a second-line agent for the treatment of hypercalcemia of the malignancy. Dose schedule of 120 milligram by subcu injection on day 1, 8, 15, and 29, and then every 4 weeks thereafter. Associated with adverse effect including nausea, it should be monitored for. This article showing the efficacy of the denosumab with hypercalcemia of malignancy despite of the bisphosphonate therapy. Management of the hypercalcemia for the patient with the weeks or the days of the life expectancy. It is associated with many common issues like advanced cancer such as delirium, pain, and constipation. So appropriate treatment of hypercalcemia may help to improve the patient's quality of life, but goal of the care should guide the overall treatment approach. And for patients who are expected to have the days of survival, reversal of the hypercalcemia may not be necessary. Second common disorder is hyperkalemia. Serum potassium level greater than 5.5 milligram per deciliter is considered as a hyperkalemia. It is common in patients with malignancy and chronic kidney disease among the palliative care patients. Causes of the hyperkalemia are increased intake like IV fluid which contain the potassium, high potassium containing food, potassium containing drugs, tissue breakdown like bleeding into the soft tissue, GI tract or body cavity, hemolysis, rhabdomyolysis, and the metabolic state. Shift of the potassium out of the cell, which is due to the tissue damage, metabolic acidosis, aldosterone deficiency, or the hyperkalemic periodic paralysis. Impaired excretion is due to acute renal failure, potassium-sparing diuretics, reduced tubular excretion like Addison's disease, and effective circulatory volume depletion. And pseudohyperkalemia is due to traumatic hemolysis during the blood draw. Clinical features of the hyperkalemia, it is often asymptomatic until the plasma potassium concentration is above 6.5 to 7 mg per liter. The clinical feature include severe muscle weakness or the paralysis. It can cause the ascending muscle weakness that begins with the leg and progress to the trunk and arm, and can progress to the flaccid paralysis, mimicking the GBS. Sphincter tone and cranial nerve function are typically intact, and respiratory muscle weakness is rare. And these manifestations resolve with the correction of the hyperkalemia. Reduce the urinary acid secretion. Hyperkalemia interfere with renal ammonium excretion and thereby limiting the acid secretion and possibly leading to the development of metabolic acidosis. Cardiac manifestation. Conduction abnormality that may seen into the right bundle branch block, left bundle branch block, bifascicular block, advanced atrioventricular block. Cardiac arrhythmia, which is associated with hyperkalemia, include sinus bradycardia, sinus arrest, slow idioventricular rhythm, ventricular tachycardia, ventricular fibrillation, and asystole. ECG changes serum potassium level. According to that, ECG findings may be seen. Like if level is 6 to 7, then tall P waves. When it is 7 to 8, loss of the P waves, widening of the QRS complex. From 8 to 10, QRS merges with the T waves, forming the sine wave. And if it is greater than 9, we can see the arterioventricular dissociation, ventricular tachycardia, and cardiac standstill. This figure showing the early changes of in the hyperkalemia. A tall peak wave and symmetrical T wave is the first change seen on the ECG. Diagnosis of the etiology of hyperkalemia. We have to first exclude the to establish the etiological diagnosis. We have to exclude the following like moderate to severe renal failure, drugs which causing the hyperkalemia, pseudohyperkalemia, ECF volume depletion, ECF volume, severe metabolic acidosis. This is the algorithm showing the diagnosis of the hyperkalemia. First, we have to check the creatinine. If it is elevated, then check the concomitant hyperuricemia, hyperphosphatemia, or the hypocalcemia. If these are present, then it may be a renal failure. And if these are not present, then it may be a tumor lysis syndrome. If the creatinine is normal, then we have to calculate the transtubular potassium gradient, which is less than 10. It is excessive potassium due to the excessive potassium intake, and if it is greater than 10, it may be due to mineralocorticoid deficiency. Principles of the treatment for hyperkalemia. One is antagonism of the membrane effect of the hyperkalemia is due to the injection calcium gluconate. Other one, potassium movement into the cell, which is due to the insulin and glucose injection, sodium bicarbonate and beta 2 agonist. And third mechanism for treatment is removal of the potassium from the body, which is by loop or thiazide diuretic, cation exchange resin, and peritoneal or hemodialysis. Management for the patient with years or months of the life expectancy. We can treat the hyperkalemia with calcium gluconate 1 gram IV or calcium chloride 0.5 to 1 gram IV. Insulin plus glucose, regular insulin of 10 unit intravenous with D50 of 50 ml. Sodium bicarbonate 150 MEq plus D5 of 1 liter over the 2 to 4 hours. Beta 2 agonist albuterol 10 to 20 milligram inhaler or 0.5 milligram IV. Diuretics furosemide greater than or equal to 40 milligram of IV dose and hemodialysis. Cation exchange resin. The gastrointestinal cation exchangers including the tetramer, sodium polystyrene sulfonate and sodium zirconium cyclosilicate. They bind potassium in the GI tract in exchange for these other cation like sodium and calcium. And such a therapies can be used to treat hyperkalemia in patients with or without the severe kidney function impairment. The dose for the sodium polystyrene sulfonate is 25 to 30 milligram, mixed with 20% sorbitol 3 to 4 times a day. And for zirconium cyclosilicate, it is 3 times a day for the 48 hours. Management for the patient with weeks or the days of the life expectancy. Electrolyte abnormality may not be the source of suffering in the terminal phase. Hydration, fluid resuscitation, fluid restriction, or the blood work may cause the additional burden. Since the aggressive treatment can be distressful, the focus of the care is on the comfort is essential. Then hypokalemia is defined as the persistent reduction in the serum potassium below the 3.5 mg per liter and is common clinical problem, and potassium enters the body via oral intake or the IV infusion and is largely stored in the cells and then excreted in the urine. Causes of the hypokalemia are poor intake like low dietary intake or potassium free IV fluid, non-renal loss in which the urinary potassium is less than 20 mg per day, is containing vomiting, diarrhea, excessive sweating, large nasogastric aspiration, renal loss in which the urinary potassium is greater than 30, are diuretics, osmotic diuretics, salt wasting, nephropathy, steroid therapy, magnesium deficiency, redistribution, metabolic alkalosis, insulin, beta 2 adrenergic agonist. Cancer-specific cause of the hypokalemia include the tumors which secrete the ectopic adrenocorticotropic hormone, such as the small cell lung cancer, thymus or bronchial carcinoma, thyroid medullary carcinoma, or the neuroendocrine tumor. Acute myeloid leukemia M4 and M5 subtype, which have been long associated with the hypokalemia. In cancer, distinct causes. Chemotherapy leads to the hypokalemia either indirectly via side effect of vomiting or diarrhea, or maybe directly affect the renal tubular effects due to ifosfamide, cisplatin, or diuretics, or in some patients with leukemia associated with lysosomiuria. Clinical features of the hypokalemia: initial features fatigue, myalgia, muscular weakness, lower extremity, smooth muscle involvement may result in the constipation, injuries, or urinary retention. And severe hypokalemia is progressive weakness, hyporeflexia, hypoventilation, increased risk of the arrhythmia. It can lead to polyuria due to nephrogenic diabetes or cause the amniogenesis and precipitate the hepatic encephalopathy. Grading of the hypokalemia is mild, moderate, and severe. Mild 3 to 3.4, moderate 2.5 to 2.9, and severe less than 2.5. ECG changes. Early ECG changes in hypokalemia is flattening of inversion of the T waves, permanent U waves, ST segment depression, and prolonged QR interval. Severe potassium depletion leads to prolonged PR interval, decreased voltage, whitening of the QRS complex, and ventricular arrhythmia. Increase in the amplitude of the U wave, which occur at the end of the T wave, are the characteristic of the hypokalemia. Prevention of the hypokalemia. Normal potassium intake about 60 mq per day is sufficient to prevent the hypokalemia. Condition where prevention of the hypokalemia is of special importance are the digitalist therapy, heart failure, previous myocardial infarction, ISD, other diabetes mellitus. This table showing the potassium deficit according to the serum potassium like greater than 3.5, there is no potassium deficit. If potassium level 3, then approximately total body deficit of the potassium is 300. For 2, it is 450 to 600. And if serum level is less than 2, then deficit may be more than 600. Management of the hypokalemia for the patient with years to months of the life expectancy. First, we when to treat the hypokalemia. Like in the level of 3.5 to 4, no potassium supplement is needed. Increase the oral intake and add the potassium sparing diuretic. For the 3 to 3.5, treatment in selected high-risk patients and risk of arrhythmia, CHF, digitalis therapy, or the ISD. And if potassium level is less than 3, then it needs the definitive treatment. How much potassium to give and how long to treat? When average deficit of the potassium is about 200 to 400 mq, 50 to 100 mq per day of the potassium should slowly can be given. And with severe hypokalemia or ongoing loss of potassium, larger dose may be required. Oral potassium supplementation, mild to moderate hypokalemia, 60 to 80 mq per day of potassium chloride along with the treatment of the underlying disorder. And severe hypokalemia, 40 mq of the potassium chloride 6 hourly under the close monitoring of the ECG. IV potassium therapy, the caution should be taken with when give the intravenous potassium therapy, like there is a high risk of the hyperkalemia. It is reserved for the severe hyperkalemia when potassium level less than 3. Always monitor with physician. Never give the injection to KCl directly or with isolate M. Don't use the D5% as diluent. In treatment of the acidosis with the soda bicarb may aggravate the hypokalemia. How to give the IV potassium and how long? To make the tailor-made potassium chloride infusion, 100 mq of the potassium is mixed in the 1 liter of the isotonic saline. An infusion of this saline at the rate of the 100 ml per hour will deliver the 10 mq of the KCl per hour. Potassium concentration greater than 40 mq per liter can cause the phlebitis. And if we want to give more concentration, then infuse only into the large range. Potassium supplements, food which contain the high level of the potassium, like and vegetable like spinach, tomatoes, broccoli, beets, carrots, cauliflower, potatoes, and fruit like banana, kiwis, orange, coconut water. Very high potassium containing food are the dried fruits, nuts, avocados, grain kernels, wheat grain, and lima beans. Then hyponatremia. Hyponatremia is defined as the plasma sodium less than 135 mg per liter, and most common metabolic disorder encountered in patients with malignancy, which is occurring up to the 47% of the hospitalized cancer patients. This common problem in the patient with advanced cirrhosis, associated with increased the hospital length of the stay, increased mortality, and poor response to the therapy. Serum sodium reflects the relative proportion of the sodium and water. Salt replacement is required in all the hyponatremia is a wrong concept because hyponatremia may be dilutional or due to the sodium loss. And syndrome of the inappropriate diuresis is the most common cause of the hyponatremia among the oncology patients and associated with significant morbidity. Hyponatremia with volume depression, extrarenal causes like vomiting, diarrhea, peritonitis, and renal loss of excessive diuretics, salt losing nephropathy, diabetes, acidosis, cerebral salt wasting syndrome, and hyponatremia with the hypervolemia or urinary sodium less than 20 is the CHF, cirrhosis, nephrotic syndrome, And if urinary sodium is greater than 20, it may be due to the renal failure. Hyponatremia with normal ECF volume, SIADH, hypothyroidism, glucocorticoid deficiency, hypogenic polydipsia. Clinical features of the hyponatremia according to the level of the sodium, mild level 130 to 135, anorexia, headache, nausea, vomiting, lethargy. In moderate hyponatremia, clinical features of personality changes, muscle cramp, muscle weakness, confusion, ataxia. And if the hyponatremia is severe, you may see the drowsiness, diminished reflex, convulsion, coma, and also can lead to the death. Why the symptoms are primarily the neurogenic in the hyponatremia? Because hyponatremia leads to the hypoosmolality of the ECF, so the water moves into the cell and the cell becomes swell. When the cell of the brain swells, it causes the increase in the ICP, and increased ICP causes the reduced cerebral blood flow, leading to the hypoxic brain damage. As the skull is fixed and closed the space, increased the volume and raised ICP lead to the herniation. And the signs of the herniation are unequal or fixed dilated pupil, hypoventilation, cardiovascular instability, urinary or the fecal incontinence, and the respiratory arrest. Diagnosis of the hyponatremia is from the three important diagnostic tests. One is plasma osmolality. So we have to exclude the pseudo hyponatremia of the renal failure. Then urine osmolality. If it is less than 100, it may be due to diluted urine, which is suggest of the primary polydipsia, or if it is greater than 100, it may suggest the hyponatremia in which the water excretion is impaired. Then third one is urinary sodium concentration. If it is less than 15, it may be due to diarrhea or vomiting. And if it is greater than 15, it may be due to the SIDH or the renal salt worsening disorders. This is the algorithm of the diagnosis of hyponatremia. First, we have to rule out the pseudo hyponatremia, and then if hypoosmolality is there, assess the renal status. If it is impaired, it may be due to primary renal disease. But if it is normal, then assess the volume status of the hyponatremia. In hyponatremia, if there is a edema, it may be due to the CHF, cirrhosis, nephrotic syndrome, and if hyponatremia is with volume depletion, we have to check the urinary sodium excretion. Urinary sodium less than 15 may be suggestive the diarrhea, vomiting, burn, or the pancreatitis. And if urinary sodium is greater than 20, it may be due to the diuretic salt losing nephropathy. If the patient's volume status is normovolemic, then assess the adrenal or thyroid function. If there is no adrenal or thyroid insufficiency, then dilute the urine in response to the water load. If the response is positive, then it may be the psychogenic polydipsia, and no response, then it may be due to the SIADH. Management of the hyponatremia for the patient is the years to months of the life expectancy. First, treat the underlying etiology if possible, and correct with the normal or the hypertonic saline. And hypervolemic hyponatremia, loop diuretics, vasodilator to increase the cardiac output in congestive heart failure, colloid infusion in the cirrhosis, and tolvaptan if there is a refractory hyponatremia. Management for the patient with weeks to the days of the life expectancy. Electrolyte abnormality not the source of the suffering in the terminal phase. So the hydration, fluid restriction, and the blood work may cause the additional burden. So aggressive treatment can be distressful, and care focusing on the comfort is essential. SIDH is the most common cause of the hyponatremia in the oncology patient and associated with the significant morbidity. It is mediated by the excessive automatous action of the vasopressin, independent of the serum osmolality or the volume. And common finding in association with advanced malignancy and many factors which contribute, including the cardiac hepatic failure, hyperglycemia, and medications. Mechanism of the SIDH in the malignancy: increase the secretion of the vasopressin from a pituitary or the ectopic source by increased activity in the renal collecting duct. There are the three receptors which have been identified: V1A, V1B, and V2. V2 receptors are located on the renal collecting duct and mediate the antidiuresis. Following the binding of the vasopressin to the V2, V2 receptor activation result in the insertion of the aquaporin 2 channel into the apical plasma membrane of the collecting duct. And these channels allow the passage of the free water only, but they cannot allow the passage for the ion across the cell membranes. Etiology of the SIDS, meaning the small cell lung cancer or carcinoma tumor, secondary metastasis to the lung or brain mets, and pulmonary infection. Common drugs causing these are antidepressant, phenothiazines, lorazepam, carbamazepine, and cytotoxic agents like cyclophosphamide or the vincristine. Diagnosis of the SIDH is of exclusion, like all other differential diagnosis excluded, then the diagnosis is of the SIDS. First one is plasma hyposmolality less than 275, concentrated urine osmolality greater than 100, normal plasma or extracellular fluid volume, high urinary sodium excretion more than 30, and exclude hypothyroidism, hypoadrenalism, and diuretics. Treatment of the SIDH with life expectancy of the years to the months. It include a infusion of the 150 ml of the 3% hypertonic saline over the 20 minutes, followed by a repeat serum sodium test and repeat infusion of the hypertonic saline as per the guideline. Mild moderately symptomatic SIDH is fluid restriction and cessation of the offending medication. Intake should be limited to the 500 to 700 ml per day, and this takes the several days to influence the hyponatremia. Non-peptide vasopressin receptor antagonists have been developed, including the oral selective V2 receptor antagonism and intravenous V1A V2 receptor antagonism, conivaptan. In conjunction with the modest fluid restriction, Veptans have been proven safe and effective in the treatment of the chronic euvolemic hyponatremia. And oral tolvaptan, IV conivaptan are currently licensed for the treatment of the euvolemic hyponatremia. Hypernatremia. It is defined as the plasma sodium concentration greater than 145 and usually due to the water deficit, not due to the sodium overload. Causes are decreased intake in coma, depression, inability to swallow, increased loss from the skin like fever, hyperthyroid, hot environment, increased respiratory loss, hyperventilation, increased loss in the urine like diabetes insipidus, medullary cystic disease, and sodium retention in excessive IV hypertonic sodium chloride or the sodium bicarbonate. Clinical features are marked thirst, muscle weakness, rigidity, dry mouth, mental confusion, coma, intracranial hemorrhage, tachycardia, low systolic blood pressure, and focal neurological deficit. Key features of the hypernatremia are we have to identify the urine osmolality greater than 700 to 800, then check the urine sodium. If it is less than 25, it may be due to extrarenal water loss or the intracellular osmosis. And if urinary sodium is greater than 100, there may be the sodium overload due to the sodium chloride or sodium bicarbonate infusion. If the urine osmolality is less than 700 to 800, then it may be due to the renal water loss. So we have to assess the urine osmolality. If it is less than 300, the diagnosis may be the diabetes insipidus. And if the urine osmolality is 300 to 600, there may be the partial diabetes insipidus or the osmotic diuresis or the loop diuresis. Management of the hypernatremia in patients with the just 2 months of the life expectancy. Restore the access to water or supply the daily requirement of the water more than 1 liter per day. And correction should be done slowly as rapid lowering of the sodium produces the shift of the water from the PCF into the brain. And the rate of the correction should not exceed 0.7 MEQ per liter per hour. And hypernatremia is associated with the hypotension due to the volume depression. The initial solution should be isotonic saline, so to increase the ECF volume. However, if the neurological features are also present, therapy should be started with the half saline. Calculation of the free water deficit in hypernatremia. Fluid deficit is equal to plasma sodium minus 140 upon 140 into 0.6 into the body weight in kilogram. In general, 50% of this calculated deficit is given over the first 24 hours, and the remaining of the 50% is given over the next 24 hours. And in the patient which reach 2 days of the life expectancy, electrolyte abnormality is not the source of suffering in the terminal phase. So aggressive treatment can be distressful and care focusing on the comfort is essential. Then metabolic acidosis. It is characterized by the fall in the bicarbonate and fall in the pH less than 7.35. The PaCO2 is reduced by the hyperventilation, which minimizes the fall in the pH. Common metabolic disorder and the malignancy and the chronic kidney disease. Pathophysiology, it may be result from the loss of the base like bicarbonate via the GI tract or the kidney, overproduction of the metabolic acid acid in the body, ingestion of the infusion of the acids, and failure of the H plus ion excretion by the kidney. Types of the metabolic acidosis are of two types, high and normal anion gap metabolic acid. Cause of the high anion gap metabolic acidosis are methanol, uremia, diabetic ketoacidosis, alcoholic ketoacidosis, or the starvation ketoacidosis, lactic acidosis. And causes of the non-ion gap metabolic acidosis are diarrhea, laxatives, ileostomy, intestinal or pancreatic fistula, or the drainage. Renal causes like renal tubular acidosis, renal failure, hypoaldosteronism, and dilutional acidosis due to the rapid infusion of the bicarbonate-free isotonic saline as seen in the volume resuscitation. Clinical features, pulmonary changes like smooth breathing suggest the presence of the metabolic acidosis, and this hyperventilation is more due to the increase in tidal volume rather than to respiratory rate. Cardiovascular changes, increased susceptibility to the cardiac arrhythmia, decreased the response to inotropes, and secondary hypotension may occur. Reduced blood pressure in such a patient is due to the depressed myocardial contractility and arterial vasodilation, both induced by the low pH. Neurological changes like headache, confusion, lethargy, drowsiness, coma. Other changes are due to chronic acidemia, as with renal failure can cause the rickets and osteomalacia, and non-specific symptom anorexia, nausea, vomiting, and muscle weakness. First, we have to determine whether it is the high anion gap or the normal anion gap metabolic acidosis. The anion gap is sodium minus chloride plus bicarbonate. In normal anion gap, reference range is generally 9 plus or minus 4. So for high anion gap metabolic acidosis, we have to check the presence of ketone, which indicate the ketoacidosis. If ketones are negative, then check the renal function, lactic acid level, and toxicology screening. For the normal anion gap metabolic acidosis, first evaluate the history for the causes, like check the urine anion gap. If the urine anion gap is positive, then it indicates the renal cause. And if it is negative, it indicates the gastrointestinal or the other cause of the metabolic acid. Relevance to the cancer palliative care setting, dysproteinemic status such as multiple myeloma, monoclonal and gammopathy may result in the normal anion gap metabolic acidosis because they can cause the proximal renal tubular acidosis. And lactic acidosis, which is a known cause of the metabolic acidosis, is a rare complication of the malignancy. It has been observed that lactic acidosis is more often in hematologic malignancy, but also in solid tumors such as the small cell lung cancer, cholangiocarcinoma, breast cancer, or the gynecological cancer, and metastasis from the unknown primary carcinoma. Management of the metabolic acidosis in patients with years to months of the life expectancy and correct the underlying cause of acidosis like diabetic ketoacidosis, diarrhea, or the uremia. Sodium bicarbonate is generally indicated in the normal anion gap metabolism. Use of the sodium bicarbonate in the high anion gap metabolic acidosis is controversial, and it should be reserved for the patient with a pH of less than 7.1 or in the life-threatening case of metabolic acidosis. And hemodialysis may be particularly useful in patients with the renal failure. Management for the patient of with weeks to days of the life expectancy. Patient with the advanced cancer who have severe metabolic acidosis have a short survival if the underlying cause cannot be rapidly resolved. Emphasis should be placed on the interventions aimed at managing the distressing symptoms like vomiting, diarrhea, with the ultimate goal of the achieving only short-term benefit. Metabolic alkalosis. It is characterized by the increase in the serum bicarbonate, high pH, and compensatory increase in the PaCO2 due to the alveolar hypoventilation. Increased bicarbonate and increased PaCO2 is also a feature of the chronic respiratory acidosis, but a differentiating feature is low pH, and it is more commonly seen in end-stage liver disease among the palliative care patients. Hyponatremia, hypokalemia, and metabolic alkalosis are well-recognized trigger of the hepatic encephalopathy. Causes of the metabolic alkalosis are of two types, saline responsive and saline resistant. Saline responsive have, if we see a volume depletion, it may be due to vomiting, gastric suction, or diuretic use. And if there is no volume depletion, it may be due to bicarbonate diffusion or the multiple transfusion. In saline resistant alkalosis, it may be hypertensive due to hyperaldosteronism or the Cushing syndrome. And if it is normotensive, it may be due to Batter syndrome or severe potassium depletion. Clinical features of the metabolic acidosis are the lightheaded, carpopedal spasm in CNS, cardiovascular symptoms like hypotension, cardiac arrhythmia, weakness, muscle cramp, and respiratory abnormalities, which may be compensatory hypoventilation, which cause the hypoxia. Diagnosis of the metabolic alkalosis are increased bicarbonate, pH, and compensatory increase in the PaCO2. So expected increase in the PaCO2 is equal to 0.45, 0.75 into the rise in bicarbonate. Serum potassium and chloride are also usually low, and urinary chloride estimation is very useful for etiological diagnosis. Treatment of the alkalosis are due to underlying cause. Saline responsive alkalosis, aim of the therapy is adequate correction of the volume, chloride, and potassium deficit. IV isotonic saline with KCl or the isolate G are preferred infusion. Treatment with the H2 inhibitor or proton pump inhibitor will reduce the gastric acid secretion and will minimize the further H plus loss and therefore prevent or reduce the metabolic alkalosis due to vomiting or nasogastric suction. Diuretic induced metabolic alkalosis in the edematous patient is difficult to treat. Avoid or discontinue the exogenous source of the alkali such as the bicarbonate infusion, vinegar, lactate, acetate, or the citrate. In rare cases with severe alkalosis, diluted HCl can be given IV to the lower the plasma bicarbonate concentration. Dialysis therapy may be useful in occasional patients with severe metabolic alkalosis, volume overload, and renal failure. Hypomagnesemia. It is an electrolyte disorder characterized by the reduced magnesium serum level less than 1.5 and the magnesium concentration lower than 1 is defined as a severe hypomagnesemia. It occurs frequently in hospitalized patients and corrected to increase the risk of death. In cancer, patient might result from the different cause like due to the cancer in several conditions like anorexia, malnutrition, vomiting, intestinal injury, intestinal drainage of the fistula, diarrhea, malabsorption syndrome. Cancer treatment like drugs which causes the kidney damage, secondary hypomagnesemia. Cisplatin might induce the hypomagnesemia through the distal renal tubular damage. Concomitant drugs are diuretic, antibiotic, beta-adrenergic agonist, or orgasnet, and amphotericin B. And concomitant diseases like hyperparathyroid, hypothyroidism, diabetes mellitus, dialysis, renal failure, and hereditary disorders. Three mechanisms which are involved in the reduced intake, redistribution into intracellular compartment, and increased renal loss. Clinical features of the hypomagnesemia are in early manifestation may be weakness or muscle cramp, and in severe manifestation, cardiac arrhythmia, disorientation, irritability, tremors, tetany, acetosis, jerking, and confusion, as well as eventually hallucination, depression, epileptic crisis. Biochemical alterations like hypokalemia, hypercalcemia, and metabolic acidosis that might confuse clinical manifestation. ECG alteration like prolonged PR-QT interval and T wave inversion and ST segment elevation seen in the hypomagnesemia. Management of hypomagnesemia in patients with life expectancy of the years to months. Now, in asymptomatic patient, oral supplementation of the magnesium salt should be preferred. However, the diarrhea might represent a dose-limiting adverse event. In symptomatic patient, the infusion of the IV magnesium sulfate should be preferred, and the total of 1 to 4 gram of magnesium should be administered with low infusion in 12 to 24 hours until the magnesium level rises to the 1.2 mg per day. Severe hypomagnesemia patients should receive a prompt replacement therapy in order to prevent the cardiac arrhythmia and death. So the total of 4 to 6 gram of magnesium sulfate is usually required in severe hypomagnesemia. Management with weeks to days of the life expectancy. Since aggressive treatment can be distressful, we can focusing on the comfort care essential. Then hypermagnesemia. It is defined as a magnesium plasma level greater than 2.2 and is a rare electrolyte disorder and usually iatrogenic, and causes are increased intake, increased absorption, decreased excretion, diabetic ketoacidosis without treatment, and renal failure patient. Clinical features are neuromuscular weakness, lethargy, muscle paralysis, respiratory depression, hypotension, bradyarrhythmia, cardiac systole, and ECG changes like prolonged PR interval, increased QRS duration, prolonged QT interval, and complete heart block. Diagnosis is check the medication, renal function, and GI disorder. Management of the hypermagnesemia for the patient with years to months of the life expectancy. Discontinue the magnesium containing medications like laxative, antacid. Use the intravenous calcium and hemodialysis for the urgent treatment. 10% calcium gluconate 10 to 20 ml IV slowly over the 10 will effectively correct the hypotension by lowering the magnesium level. If renal function normal, then injection furosemide after dehydration with isotonic saline may be also helpful. And management for the patient with weeks to days of the life expectancy. Since the aggressive treatment can be distressful, care of focusing is only on the comfort care. Then pyrexia. It is a common in advanced cancer, and the most common cause is infection followed by the neoplasm itself. Neoplastic pyrexia refers to the specifically to pyrexia that is caused by the cancer itself. It is a diagnosis of the exclusion made only after the other causes have been ruled out. Its exact pathogenesis is not known, but it is usually a paraneoplastic phenomenon caused by the secretion of the pyrogenic cytokines in response to the tumor. And these cytokines stimulate the synthesis and release of the prostaglandin E2 from the hypothalamus, which mediate the thermal homeostasis. Other mechanisms include the release of pyrogens from the necrotic tumor tissue and direct brain tissue damage due to brain metastasis with consequent activation of the phospholipase A2. Clinical features of the pyrexia are sweating, chills, drowsiness, and confusion. And treatment episode of the often resolve with direct tumor treatment like chemotherapy or steroid-induced lymphoma. Sponging and ice pack and fans may relieve the comfort in non-pharmacological management. And paracetamol, NSAID, and steroid are effective antipyretic in the pyrexia. Due to the risk associated with the NSAID and steroid use, regular paracetamol should be used first line and ibuprofen is recommended second line. It is important to communicate the diagnosis clearly to the patient and families, including the uncertainty as they may feel the distress due to the recurrent admissions or protected investigation process. Metabolic bone disease. Osteoporosis can be precipitated by the glucocorticoid and chemotherapy, which cause the renal loss of the calcium, magnesium, and phosphate. It is common in the premenopausal women who are treated for the breast or the ovarian cancer, and in the men with prostate cancer treated with the androgen inhibition. Early assessment using the bone mineral density measurement and fracture risk calculation are important. Depending on the age and fracture risk, common treatment used in the treatment of the osteoporosis include the calcium and vitamin D supplementation, bisphosphonates, zumab, and hormone replacement therapy. Hyperglycemia. The prevalence of hyperglycemia in the cancer patient is higher than that of in general patient and general population, and it is estimated that 8 to 18% of the cancer patients have coexisting diabetes mellitus. It may be caused by pre-existing diabetes mellitus or cancer-related treatment or tumor-related effect. Pre-existing diabetes mellitus, whether it is type 1 or 2, independent risk factors for both the incidence and mortality of the cancer. Hyperglycemia, hyperinsulinemia, and obesity all known to promote the cancer onset and progression. Cancer-related treatment, corticosteroids, the most common cause with diabetes mellitus occurring in the 10% of the patients treated with corticosteroids, and cancer immunotherapy like immune checkpoint inhibitors, ipilimumab, often used in treatment of the metastatic melanoma. Targeted therapy like tyrosine kinase inhibitor, mTOR inhibitor, and somatostatin analog therapy. Tumor impact. Anorexia cachexia syndrome, a systemic response to advanced cancer, is associated with abnormal carbohydrate metabolism, includes the gluconeogenesis and Cori cycle activity, leads to the hyperglycemia. Treatment of the hyperglycemia in advanced cancer patients. First, prevent and treat the hyperglycemia related symptom. Avoid the hypoglycemia. and avoid the diabetic emergency like ketoacidosis or the hyperosmolar hyperglycemic state. To achieve these goals, a target blood glucose level range from the 6 to 15 millimole per liter recommended for the patient in the last year of the life. For people with the type 2 diabetes, metformin has the advantage of not inducing the hypoglycemia but may not be tolerated in the elderly patient. And if used, it should be titrated up very slowly to avoid the gastrointestinal side effect. And it should be avoided or stopped in those with an estimated glomerular filtration rate of less than 30 ml per minute or creatinine greater than 150 micromole per liter. Short-acting insulin secretagogues like repaglinide taken within the 30 minutes of the food if oral intake is variable due to the vomiting. For the people with type 1 diabetes, it is likely that insulin therapy will need to be reduced as oral intake activity and renal function decline. However, all the people with type 1 will continue to need the basal insulin until the death, and it should be never be stopped completely. Corticosteroid-induced hyperglycemia. It should be treated if the symptomatic and prolonged course of corticosteroid treatment is planned. Once daily dose of the morning short-acting sulfonylurea or the morning isofen insulin would be suitable for the first-line treatment, reducing the risk of the nocturnal hypoglycemia. Anti-diabetic treatment should be reduced in tandem with corticosteroids to prevent the hypoglycemia during the corticosteroid treatment. These are the references for this today's discussion. Thank you.
Good morning, everybody. Thank you, Dr. Varun, for a very comprehensive and exhaustive presentation. Excellent. I think the postgraduates needn't even go back to their clear and with all the practical implications of how treatment has to be aligned with goals of care. May I request the moderator, Dr. Ravi, to say a few words in closing for this presentation, sir?
Yeah,
Dr. Ravi?
I would like to summarize that because under is very necessary. Yeah, may I? Hello.
So your voice is breaking a bit.
Hello.
Hi, yes, sir. Yes.
Yeah, I want to conclude that understanding of the various metabolic disorders during admission of palliative patient, so we can early recognize that complication and treat aggressively for the better symptomatic control of the patient, as that these disorders have many etiology, and due to disease itself or due to the treatment of the disease, and we have to plan according to the patient condition and the cause of the disorder. So we can as patient and
Thank you, Dr. Ravi. There are a lot of congratulatory messages for Dr. Varun's presentation in the chat box. No questions yet. Any of the senior faculty in the meeting would like to say a few words?
Hello.
Yes, madam.
Yeah, a very good presentation. Congratulations to Varun and Ravi. And as Ravi said, for metabolic disease, appropriate understanding and appropriate diagnosis and treatment is necessary. So I request all PGs to go back and read in detail. Thank you.
Thank you, madam. Any of the other senior faculty would like to say anything? We still have 1 minute to go for 7:30. So there's a question: how frequently should we do ABG for our patients, especially when they are terminal? Dr. Varun, would you like to take that question?
Frequency of ABG, maybe we have to first assess the patient's life expectancy. If it is of like 2 or 3 days or 1 week, it may be I think distressful for the patients to repeatedly do this ABG because it may be more traumatic to the patient.
Absolutely. That's correct. As you have already mentioned in your presentation, that it has to be aligned to the goals of care. And symptomatically, if it is going to be better, we should go empirically rather than do an invasive ABG, which may not be even present in a palliative care unit. All right. I don't think there are any further questions. The time is 7:31. If it's okay with everybody, we will call this meeting closed, and we will meet again next Monday, just before 6:30 for the next IAPC academic session. Thank you everyone for joining. Thank you, Dr. Varun, again for a very comprehensive lecture.
Thank you, ma'am.